Oh, here we go.
You all right there?
Yes, that's fine.
Okay.
Thank you very much, and it's my pleasure to be here today and to talk to you about this topic, Mr. Chairman, ladies and gentlemen. They're my disclosures. I'm going to tell you that BP targets make no sense in kidney disease or really in any person. Most of us have a blood pressure that's well above what our ideal level should be, and we've got a lot of proven treatments that we know reduce blood pressure, and we should use these in people at high risk wherever they're tolerated. And we shouldn't be afraid of lowering blood pressure to well below what's currently perceived to be recommended targets. And the reason for that is this. Every time someone gets up here to talk about targets, they give you a new answer. How any of us are supposed to keep up with that information, let alone actually manage our patients appropriately, is impossible. But it's more complicated than that as well. Over time, we've had a progressive reduction in the targets or in the people who should be treated with blood pressure lowering. In the 1950s, there was a massive debate about people with malignant hypertension. It was argued very strongly by some of the most eminent professors in the world that if we lowered blood pressure in people with malignant hypertension, we would kill them because we'd cause them to have strokes due to cerebral hypoperfusion. Clearly, that was proven to be wrong. And the same argument's been had over successive decades at each different level of blood pressure, such that we've now got down to a stage where this absolute risk concept is taken over, where we lower people's blood pressure if they're at high absolute risk of cardiovascular events, regardless of where their blood pressure starts. And the reason we do that is because of data like this. In the general population on the left, in a 1 million person study, or in this 4 million person study on the right-hand side, that shows a clear direct linear relationship between blood pressure and the risk of coronary disease, the risk of end-stage kidney disease. Exactly the same data exists for stroke and other outcomes, showing that the lowest blood pressure is actually in people with a blood pressure below 120 millimetres of mercury, well below established targets. And that raises the question, if they're at the lowest risk, what's normal? Should we all be exactly 6 foot tall, or do we accept that some people will be 5 foot tall, some people perhaps even smaller, whereas other people may be much greater? We do that for height, we accept it for weight, for a whole range of other purposes. Why do we presume everyone should have the same blood pressure and therefore the same blood pressure target? If we want to truly know what's normal, we have to look back to our physiology and look at the sort of people who are living the life that our bodies are evolved for. These are the Yamamomo people from South America who had no contact with Western civilization until the 1970s and live a traditional lifestyle with no salt, lots of exercise, no obesity and no overweight. And this is what happened when they were studied in the 1970s. This was the average blood pressure across the population. You can see that it was about 100/70, both men and women, and more importantly, the same with increasing age. Absolutely different to what we see in our society, where a whole range of parameters cause our blood pressure levels to be pushed up. If this is the normal distribution with an average of around about 100, and I'll remind you that blood pressure is a bell-shaped phenomenon, we don't have a single peak of blood pressure in any society. We have a number of drivers. We have salt, we have sloth, we have cars, and the stress that goes with them, leading to a range of problems that cause our blood pressure as a community to push towards the right. So that someone who's got a blood pressure of 120 today, their natural blood pressure may well actually be 90 millimetres of mercury, as we see in many women, for example, and that's perfectly normal. That's not a disease. That doesn't mean that we need to change their blood pressure. What about trials? What do the trials tell us? Well, this trial is one that's often quoted, the ACCORD study, which reported as a negative study, showed that more intensive blood pressure lowering to less than 120 millimetres of mercury compared to people with their blood pressure lowered to less than 140. People say this is a negative trial, but look at this. The risk of stroke was reduced by almost half, with a highly statistically significant p-value. And stroke, of course, as we've just been hearing from the other two discussants, is one of the most devastating and important conditions to prevent. So I see this as a very positive and very important outcome. Why was the primary result negative? The answer is because the study was underpowered. It was finished early, the event rate was almost half of what was expected, and as a result, the study had 67% power rather than the more than 90% power that was originally planned. So no surprise that that trial was negative. If we then look at all the other trials and improve our power by pooling the data from a range of trials looking at different targets, we find a very clear and statistically significant benefit. And indeed, we find consistent benefit from lower targets compared to higher targets, regardless of what those targets are. Every target that's on here from 150 down to 120 in accord suggests benefit. What about kidney disease? Well, here's the results for end-stage kidney disease from a similar analysis in the general population. Again, a statistically significant 10% reduction in the risk of end-stage kidney disease with lower targets compared to higher targets, with, again, very consistent results at a range of different blood pressure levels. And if we focus that on people with CKD, as is done in this analysis, currently in press at the Canadian Medical Association Journal, there's a highly statistically significant 20% reduction in the risk of end-stage kidney disease. So clearly lower blood pressures are better. But the problem with many of those trials is that they've looked at the effect of different targets. And targets are a problem, and I'm going to explain to you why targets are a problem. We should get rid of them. This is a glucose target meta-analysis looking at trials of glucose lowering, and you see here the ACCORD and the ADVANCE trial, which had almost exactly the same target, got completely divergent results for cardiovascular death. One suggested benefit, the other showed clear evidence of harm, yet they went for the same target. How is that possible? We've also got many other studies, target trials, for example in kidney disease with haemoglobin correction, which have also shown us harm. There's a fundamental problem with targets, and the fundamental problem is this: targets ignore the fact that how you achieve a goal is at least as important as what the goal is. This is data from the ALL-HAT trial looking at different blood pressure lowering agents and looking at the effects on cardiovascular events, showing that two different drugs, doxazosin and chlorthalidone, that achieved the same blood pressure reduction got vastly different results in terms of the outcomes. So people who have achieved the same target with one agent will not necessarily get the same benefits or harms as people who use another agent. There's lots of other problems with targets. Why on earth would we say that a 40-year-old who's otherwise well, who has a blood pressure of 150 on 90, should have exactly the same blood pressure goal as an 85-year-old person with multiple comorbidities, maybe chronic kidney disease, a blood pressure of 170 on 90 on multiple treatments? Do we really think that we need to get both of these people's blood pressure to the same goal? It makes absolutely no sense. The other problem with targets is we're using a measurement which is inherently unreliable to base our treatment decisions on. This is an ambulatory blood pressure measure from someone who has hypertension, and you can see here the range of blood pressure values obtained. If I happen to see the person at this time, I would say that their blood pressure is 160 millimetres of mercury. If I see them at this time, I would say that their blood pressure is 100 millimetres of mercury. My treatment decisions and my management of that person will be completely different depending on which of those I do. So fundamentally, the problem here is we can't measure blood pressure properly, so how on earth can we set a target for it? Similarly, I've shown you that blood pressure is distributed in a bell curve. Is this the way we think we're going to be able to change people's physiology? We're completely ignoring the natural order of things if we try and achieve this. To get people's blood pressure below 140, what we really have to do is shift the entire population curve to the left, which means getting some people down to 90 or 100 or perhaps even lower. Is it safe to do that? Can we lower people's blood pressure who have normal blood pressure, supposedly less than 140 on 90, and achieve benefit? Well, this meta-analysis published in JAMA almost 2 years ago now clearly shows us that you can. It pulled the data from normotensive, less than 140 on 90 people, treated with blood pressure lowering, and showed a very clear and highly statistically significant 17% reduction in cardiovascular events that was consistent for MI, stroke and heart failure, and importantly a clear reduction in the risk of cardiovascular death and all-cause death in these people with normal blood pressure treated with blood pressure lowering drugs. So it's not just hypertensive people who benefit. And we've got more data like this. This is a meta-analysis of 147 randomised controlled trials by Walden Law, showing again that even people with a blood pressure at baseline below 120 treated with blood pressure lowering agents had a further reduction in the risk of coronary disease. So why are we ignoring these people? Why are we only focusing on those people above 140 on 90? And finally, some data from the ADVANCE trial showing that the same is true for renal events. In this study, that even people with a blood pressure below 120 on 70 had a reduction in the risk of renal events in that study when treated with further blood pressure lowering therapy. So all of us have a blood pressure that's likely to be elevated compared to what our natural blood pressure should be because of the lifestyle that we live. We are ignoring physiology if we suggest that a single target fits all of us and that a single approach fits all of us. It's clear that lowering blood pressure prevents cardiovascular events even within the normal range, and different drugs differ. So we should forget about targets. What we should do is we should treat blood pressure in all of us. We should modify all of our lifestyles as the first step towards lowering our blood pressure. In those people who are at high risk of cardiovascular or renal events, we should use those drugs for whom we have a known risk-benefit profile and that are proven to reduce the risk of events, and set and forget them. Put them on them and leave them as long as they're tolerated. And Dr. Apple kindly sent me this picture of himself, which shows that he clearly agrees with my arguments. I'll hand over to him.
Thank you very much. Now we'll hear the other side of the coin.